We're now going to discuss erectile dysfunction. Erectile dysfunction is defined as the inability to achieve or maintain an erection for sexual intercourse. The term that has been used many years before is impotence, but today most of the time you're going to see the term ED or erectile dysfunction used in any kind of literature as we look at it. Your reading assignment again is your IGGY, Chapter 75. The erectile dysfunction begins on page 1642. Also from the Nursing Reference Center under the disease processes, erectile dysfunction, impotence, and overview to look at it to kind of reinforce what your book has to say. Again, just like always, we're going to look at the incidence, we're going to look at the etiology and pathophysiology, the assessment, and the treatment of erectile dysfunction. Incidence, erectile dysfunction affects 25 to 30 million men in the United States. 1% of men have primary ED, and primary means they've never been able to have an erection. This is something that has been going on since birth, while 10 to 20% of men have secondary erectile dysfunction. One of the things you need to understand as we look at erectile dysfunction, the presence of erectile dysfunction is a very good predictor of coronary artery disease. Typically what will happen is you will see erectile dysfunction as a function of cardiovascular disease occurring 3 years before you actually begin to see symptoms from coronary artery disease. So it is a great predictor of someone who has coronary artery disease. So if someone comes into the office and is having problems with erectile dysfunction, if it isn't of an organic status, then we need to be doing workup to look for coronary artery disease on these patients. New onset of ED in men in their 40s associated with a 50% fold increase in the incidence of coronary artery disease over the next 10 years. So we're really seeing that this does indicate and point toward cardiovascular disease. When we look at erectile dysfunction and look at the etiology and the pathophysiology, we're looking at primary, which we talked about, is basically this is someone who's never been able to have an erection. There's some type of genetic or some type of malformation or something that is preventing them from having an erection. They've never been able to have an erection. The main kind that we're going to look at is secondary. And as we look at secondary, that's broken down into organic and functional. Functional basically is there's some psychological reason for this patient not to be able to reach an erection. When we talk organic erectile dysfunction is a gradual deterioration of function. The man first notices a diminishing in the firmness of the erection and then a decrease in frequency of erections. Causes of organic erectile dysfunction can be inflammation of the prostate, inflammation of the urethra, inflammation of the seminal vesicles, can be after surgical procedures such as the prostatectomy or transurethral resection of the prostate, can be related to pelvic fractures, can be related to lumbosacral injuries, can be due to vascular diseases and hypertension, chronic neurological conditions such as Parkinson's disease or multiple sclerosis, endocrine disorders such as diabetes, which is a major cause as we begin to look at it. Remember, diabetes is also a major cause of cardiovascular disease. Thyroid disorders, smoking and alcohol, drugs such as antihypertensives, and this is one of the things that we see that we have a lot of trouble with men who are taking antihypertensive drugs. Some of your diuretics, the hydrochlorothiazide has this side effect. Your beta blockers have this side effect. So as you're teaching patients about their antihypertensive medications, you need to let them understand if this does occur, don't just stop taking the medication. Come back in, let us reassess, and let's try something different. Because there are medications that may work for you, so we need to make sure we work on that. And then overall poor health can cause these type problems as well. Now, functional or psychological erectile dysfunction usually have normal nocturnal or nighttime and morning erections. Typically, what we see is a sudden onset and follows a period of high stress in these patients. When we look at this, typically what happens is an erection is expected when the person reaches rapid eye movement sleep. So as we begin to talk about some of the studies that need to be done later, you'll understand what I'm talking about. Assessment, of course, we need to do a good history and physical on these patients. The history, we need to talk about, when did this issue begin? How long has it been going on? Were there problems before? Is there any history of surgeries to the area? Any history of sexually transmitted diseases? All of those type of things. Really, the first thing is to try to determine, is it an organic issue or is it a functional issue? So we really need to look at those type things, and part of that history. Complete physical exam is looking at the penis, looking at the scrotal regions, looking at all those to make sure there's not something physically going on with that patient as well. Again, that's going to be taken care of by an advanced practice nurse or a physician, not something that we as nurses on the floor are going to be taking care of. Labs, we're going to draw LH and FSH and testosterone levels on these patients just to make sure, because if there's too low of a testosterone level, that can lead to the organic erectile dysfunction. Other things that we may do for these patients may be a duplex Doppler ultrasound, and what that does is provides us information about the arterial and venous blood flow into the penis. And it can help us determine what type of treatment we may want to use for the erectile dysfunction. The other thing that we'll do is called a nocturnal penile Thompson study. Basically what happens is the patient is sent to a sleep lab, and the study can help determine whether the erectile dysfunction is caused by an organic or functional problem. If the man has nocturnal erections, then we know that erectile dysfunction is functional. That person is then sent to counseling and on an as-needed basis, maybe to a certified sex therapist or other qualified specialist to help them work through these psychological issues for that process. Treatment. We talked about the treatment for functional. The treatment for functional is actually getting these patients to counseling or to a sex therapist to help them work through those issues. Now, as we look through the treatment for the organic issues, remember that to have an erection, that basically several things have to occur to have an erection. You have to have stimulation, have to have nerve impulses, and then you have to have good blood flow to have an erection. So many of those are going to be looked at to try to figure out what is going on with these patients. Medications, and most of you who've watched any TV are aware of the different medications that are out there. The phosphodiesterase 5 or PDE inhibitors. Those are your things such as the Viagras, the Cialis, all of those medications. These drugs work by relaxing smooth muscles in the corpora cavernosa so that blood can flow into the penis. Okay, the veins exiting the corpora are compressed and limiting the outflow of blood. So basically, what happens is an erection. We need to make sure that with these medications, we're instructing our patients not to take alcohol before these medications, because that can cause problems along with it. And make sure that they understand not to take any type of nitrate medications. The combination of nitrate medications and these PD5 inhibitors can cause a severe drop in blood pressure. The other thing, if we're doing these medications, we need to explain to these patients, if they have an erection lasting longer than 4 hours, they need to get in and seek medical care. And we'll talk about priapism a little bit later. But also understand, if this erection goes on for that long, it can cause permanent damage, so they need to make sure they're doing that. Some common side effects of the drugs basically are headaches, dyspepsia, facial flushing, stuffy nose, all of those can be taken care of. You'll need to look at the different medications because different medications are designed for different usages as far as timing of intercourse, and that would be based on the specific drug. And I'm not going to get into those type issues. Okay. One of the oldest devices out there is a vacuum constriction device, where this tube is actually placed over the penis, and it creates a vacuum next to the skin. And basically, as that vacuum is increased, blood is drawn into the corpora cavernosa and begins to fill. A rubber ring is then placed at the base of the penis to prevent blood flow from going out, thereby creating an erection. Again, a lot of people complain that basically it's very painful, especially that rubber ring around the base of the penis. It also takes away from spontaneity. So it's not something that is used a lot anymore, but it's still very effective, and you may see it used some. Penile injections in another way. Drugs are injected into the penis, allowing it to engorge with blood. The most common agents that you're going to see used are Caverject, Pavarine is a vasodilator, and Regitine. Regitine is also a drug that we'll be talking about next semester as we talk about different types of vasopressor drugs being given IV. So you may see those type used. And you may see a combination of these drugs being used. The other thing that you may see basically are implants, or basically there is a balloon placed in where the corpora cavernosa is, and actually the patient can, or the person can actually then inflate that balloon as they get ready for sexual intercourse. The inflation device is placed inside one of the scrotums, and they just have to pump that up to get an erection. I have seen these used and are still in use today. Some men tend to like them because there's no drugs involved. You don't have to worry about it, and the erection could go on as long as they need it to. And it's real easy to use, and typically doesn't take away from spontaneity, is what the patients will tell me. But erectile dysfunction is something that you're going to deal with. Make sure, one of the things you do as you're doing your interview for your patients, you have to ask them about their sexual function. Don't be shy. These days it's not as bad because there are so many commercials out there that are talking about erectile dysfunction. It's sad that the children can't watch TV without seeing this and have to ask questions, our younger population, but it is what it is. So be aware that these are some of the things that you will be dealing with, some of the things you may have to ask patients about as part of your comprehensive history as you're seeing these patients. So just a quick review, basically, when we look at erectile dysfunction, it's broken down into organic and functional. Organic means there's some type of physiological reason. Functional means there's a psychological reason. The biggest treatment these days are the PDE5 inhibitors, your Cialis, your Viagra's. Those are the drugs that we're looking at, and those type of things. And it has really made a big difference in the lives of patients. One of the things that I was reading recently, there has been an increase in sexually transmitted illnesses or sexually transmitted infections or diseases in men and women over the age of 50. And they go back and look to see the rise started about the time some of these medications came out. So you also may want to talk to your, don't be afraid if your patients are over 50, over 60, to talk to them about these things. Remind them that it's just important for them to use protection as it is the teenagers, that there are sexually transmitted diseases out there that they can get, and they need to be aware of that. All right, have a good day. We'll move on to the next section in just a few moments.